So today, our focus would be on doing some MCQs regarding pH balance. Here, there will be 4 to 5 questions, which where most of the things are related on the clinical scenarios that you come across in day-to-day handling patients. But perhaps this will be little bit beyond your expertise when if you have not done your appointment yet. So clinical. So here the first question is actually about type 4 renal tubular acidosis. Again, something that usually you come across when you are doing pediatrics as well as medicine. But if you have not done your appointments, you may have not heard about these. But there are few conditions that you might actually want to study about if you are going through electrolytic as well as pH balances. So renal tubular acidosis are of 4 types: type 1, type 2, 3 and 4. Type 1 is actually it's the reduced H plus secretion. The problem is localized in the distal part of the renal tubules, which is particularly in the distal convoluted tubule. Then and it is also involved with a loss of calcium through urine, and sometimes involves in the formation of nephrocalcinosis as well. So these are some few facts that you might need to remember, but again, this is not required when it comes to the question. So type 2 is in fact the reduced bicarbonate reabsorption. Reabsorption is reduced. So this is more or less a problem that is localized to the proximal part of the renal tubule. And then type 3 is a combination or a combo of type 1 and 2, type 1 plus 2. Then type 4 is a problem that is associated with the inability of the tubules to act on the presence of aldosterone. So it has reduced sensitivity to aldosterone. So these are the 4 types that you come across. Now here the question is about electrolytic disturbances in most commonly associated with metabolic acidosis caused by renal 4 tubular acidosis. So what you see in type 4 is that it is not acting in the presence of aldosterone. The receptors are not very functional. Therefore, now because the aldosterone is not acting, now what does this aldosterone do? Aldosterone absorbs or reabsorbs sodium, takes in sodium and allows potassium to go out. The same thing happens in few other there are other protein channels that are involved, particularly in the distal convoluted tubule, which does this function by reabsorption of sodium. This happens as an active process, where sodium is exchanged in preference to H plus. So H plus is secreted out into the urine. So this is urine and this is blood. So once aldosterone is not very active enough, what would happen is that so the receptors are not functional enough and not sensitive to aldosterone. What would happen? The reabsorption of sodium and the secretion of H plus is hindered, and hence what would happen is that there will be retention of H plus within the blood plasma, leading to acidosis. And also the sodium reabsorption is somewhat reduced, and therefore there is a possibility sodium level could be slightly low than that of normal, so hyponatremia. And also the potassium levels, what does aldosterone usually do? Aldosterone usually allows the potassium to go out, or allows secretion of potassium. So this does not happen, therefore there will be retention of potassium, so hyperkalemia. Now what does the tubules do in respect to the hyponatremia? So what it does is that there are sodium chloride transporters or channels that are present particularly in the collective ducts, where sodium will be reabsorbed along with chloride. So what would happen is that there will be hyperchlorosis. So in fact, what you would expect in this question is that there is a possibility that you would see both hyperkalemia and hyperchloremia, right? Hyperchloremia, right? So the the correct answer that we can choose is actually B. So it is B, right? So we'll move on to the next question. Again, a true and false question. So that was a single best answer. So here it's a true or false question where it is about buffering systems. Now we can just go through the answers as we read along. The bicarbonate buffer system is the most important extracellular buffer in the blood, as I have mentioned this earlier as well. So bicarbonate is the most important one, which actually has the most content and it has the highest buffering capacity as well. So what you would see is that this is a true statement, and you have to mark it correct. The phosphate buffer system plays a significant role in buffering pH in blood compared to intercellular and renal system. Now, actually, this is false because it is in fact done by the bicarbonate system. So, false. Hemoglobin contributes to buffering of acids in the blood by binding to hydrogen. Yes, it can form HHB, if I'm correct. So, it is a true statement. The protein buffer system is more effective inside cells than in plasma. Yes, because protein and ions are very much greater in capacity in the intracellular area in comparison to that of blood plasma. Because in blood plasma, the majority of the work is done by the bicarbonate system, not the proteins. But within the cells, the bicarbonate is quite low and the concentration is quite reduced. Therefore, if there's any sort of an change that happens within the pH within the intracellular system, the protein system kicks in and maintains the homeostasis. So it is a true statement. Carbonic anhydrous, if you can remember carbonic anhydrous, carbon dioxide plus water, it is broken down by this enzyme to form a proton and a bicarbonate ion. So conversion of carbonic acid to carbon dioxide and water in the lungs, aiding in the excretion of carbon. Here it should be carbon dioxide. So yeah, this happens. So other way around, it does the same process. So it is a true statement. Right. So the third one, this actually is a little bit of a tricky question. If you have not done your surgical appointments, yes, you might not come across these things, but still, more or less a valid question that is applicable even in your uh, preclinical state, where you have to find answers regarding the electrolytic as well as the electrolytic imbalances as well as the pH imbalances where it is applicable. So for each of the following statement regarding intracutaneous fistula, now the questions is in fact employed upon intracutaneous fistula, uterostomy, ureterostomy, and pancreatic fistula. So this can be rather simplified by the process or the content that is present. So intracutaneous fistula, what does intracutaneous fistula means? It is actually a connection that is present between, let's assume it is the small bowel and the skin. So whatever that comes through the small bowel now is transported or diverted to the surface of the skin. It comes out through the surface. Rather a troublesome condition, but still, this is what it happens. So, if it bypasses the small intestines, there is not enough time for the reabsorption process to take place. Now, the content that is present within the small intestines is composed of both bicarbonate, sodium, as well as potassium. So, a high functioning, a high output intracutaneous fistula, which accounts to more than 500 milliliters per day, would actually allow large amount of potassium, sodium as well as bicarbonate loss from the system. Therefore, it will cause, because of the loss of the bicarbonate, it can cause metabolic acidosis. So here Intracutaneous fistula. Intracutaneous fistula often lead to metabolic acidosis due to the loss of bicarb-rich fluids from the gastrointestinal tract. It is a true statement. It is a true statement. Right. So uterostomy. So what does uterostomy means? Uterostomy is actually where you find now there. This is the kidneys. If I can. Now these are the kidneys. These are the ureters. Now what happens is that the ureters are diverted if this is usually done when there's some sort of a block, a bladder outflow obstruction, which will prevent the urine from flowing out. Then we do it surgically as well. Sometimes it is done. It happens due to surgeries, as some sort of a complication, but sometimes it is done as a surgical intervention where the ureter is taken out through the skin. Now, what happens is that because there is this rapid loss, through the fistula, there will be a possibility for major ions such as sodium and even bicarbonate to be lost from the system. Now, once this happens, it will lead to a metabolic acidosis. Now, the other thing that we usually see is that in metabolic acidosis, we try to, according to the level of chloride ions that we get, we try to differentiate it as HAGMA, high anion gap metabolic acidosis, or normal anion gap metabolic acidosis. Here, what you see is that there is excessive loss of bicarbonate along with sodium, so there will be a sort of a normal anion gap metabolic acidosis. So that is a NAGMA. So you see bicarbonate loss and also a sodium loss that is happening from the system, from our system, therefore leading to a normal NI. And there's also there's something that you need to know. There is also chloride retention that happens with this. Chloride retention happens because of now since there's this loss of bicarbonate from the body. Now there are exchange systems. A loss of because of the bicarbonate loss, there will be a compensatory mechanism that usually happens within the bowel, where there will be reabsorption of both bicarbonate and chloride to compensate. Because of this, there will be hyperchloremia. Hence, there will be a more or less a normal anion gap. So what you see here in uterostomy, a typical results in metabolic alkalosis due to excessive loss of chloride and bicarbonate. No, it's actually metabolic acidosis. So this is a first statement. A pancreatic fistula. So what does the pancreas secretes? It's a basic sort of a secretion which contains of bicarbonate. So if there's a fistula in the pancreas, there will be unavoidable loss of bicarbonate ions from the system. Therefore, what would happen? There is a possibility it could lead to metabolic acidosis. So, because of the bicarbonate loss. So, in pancreatic fistula, there is a metabolic acidosis, and this is because of the loss of bicarbonate ions. Pancreatic fistula can cause metabolic alkalosis. It's incorrect. It's acidosis. It's loss of enzyme rich. It's actually because of the bicarbonate loss. So this is a false statement. Now a high output ureterostomy can result in hypokalemia due to potassium loss in urine contributing to metabolic derangement. Right. This is in fact a true statement. It is because, as I said, high output uterostomy can lead to loss of both sodium bicarbonate as well as potassium. So the potassium loss could be extreme because the electrolytic imbalance, some sort of, now once this flow is quite extravagant, there could be excessive loss of urine, which does not allow the collecting duct to reabsorb, collecting duct and the distal part of the convoluted tubules to reabsorb much. So there will be excessive loss of potassium ions, and hence there will be hypokalemia, which will lead to particular consequences such as muscle weakness and even arrhythmia because of the electrolytic disturbances that happens in the blood plasma. Right. So bicarbonate, sodium and high potassium loss is something that you see in high output ureterostomies. Right. So this is actually a true statement. Intracutaneous and pancreatic fistulas are both associated with hypovolemia, which can worsen metabolic derangements to reduce. Now there is something called uh, this is known as there's a separate entity which is known as the volume contraction and the renal compensation. Now what happens is that because of the intracutaneous fistula and the pancreatic fistula, which can lead to excessive loss of fluid, right? So excessive loss of fluid which can cause hypovolemia. Hypovolemia. Reduced ECF value. So intracutaneous both associated with hypovolemia. That's true. Which can worsen metabolic derangements. Yes, because of the hypovolemia, there is a possibility that it might lead to secretion of or the activation of renin, angiotensin, aldosterone system and the secretion of aldosterone. Now what does aldosterone do? Aldosterone involves in reabsorption of, now what happens is that particularly because of the high output systems you would lose ions. Both there will be hyponatremia and hypokalemia along with bicarbonate levels leading to metabolic acidosis. True. And along with that, there will be hypovolemia as well. But with that, there's something that I need to emphasize is the fact that there will be an elevation of or activation of the renin, angiotensin, aldosterone system, which will lead to secretion of aldosterone. Now, the aldosterone tries to make some sort of amendments. It tries to reabsorb sodium, but in the meantime, it will cause further loss of potassium, and further loss of uh, excessive loss of potassium, particularly. So, what would happen? The hypokalemia would be very much uh, extravagant, and also it will pose a rather a larger numerical value than it's supposed to be. So, this is what aldosterone do. So this is known as the volume contraction phenomena. Right. So this is a true statement. Right. Now, this final question is about loop diuretics. Now, if you can remember, what does diuresis means is that diuresis is the loss of water. There are chemical agents which can do this. Along with this, these chemical agents usually act upon certain transport channels that are present within the renal tubules, which will prevent the reabsorption of sodium, chloride, and even potassium. And these acts on different parts of the renal tubule system, and by reducing the reabsorption of sodium reabsorption of sodium, it will prevent the absorption of water as well. By doing so, it will produce a higher volume of water within the urine and causes diuresis. So this is what it do. So loop diuretics can cause metabolic alkalosis by increasing the excretion of chloride, sodium, leading to volume contraction. Now, as I said, if the protein channels are not active, if the protein channels are not active, there's a possibility that it will lead to loss of these ions. For an example, for a certain diuretics which will act on the sodium, potassium, chloride, symporter will be preventing reabsorption of all of these. So it will cause hyponatremia, hypokalemia, and hypochloremia as well. So by doing that, it will allow the water to be passed out through urine. So there is a higher volume of urine, but and also the urine osmolality would be high as well, because there is excessive loss of electrolytes. But there is increased fractional loss of sodium, but it will lead to volume contraction. So volume contraction means there is reduced volume, because ECF is there is loss of uh, excessive amount of urine, which will cause uh, hypovolemia. So volume contraction, yes, through the increase in excretion of chloride and sodium. Yes, by doing so, it causes volume contraction. True. Thiazides. Thiazides are actually like loop diuretics. These thiazides are a diuretic agents which act on the sodium acts on the sodium chloride co-transporter that is found within the DCT, distal convoluted tubule. By doing that, it will prevent the reabsorption of sodium and even chloride. But the problem is with the bicarbonate. Now, how it does it then is that because of the excessive loss of water, now there is volume contraction, as I said. So volume contraction. With the volume contraction, there will be the activation of the renin, angiotensin, aldosterone system, as I specifically said in the last question. So it will involve the production of aldosterone, right? So aldosterone will act on sodium NaH plus uh, exchanger, absorbing sodium and allowing the hydrogen ions to be secreted. And the aldosterone will act on other ion channels as well, trying to compensate the sodium loss, because what aldosterone tries to do is to increase the sodium content in the plasma. Now by doing that, the H plus will be secreted. Now how does the H plus is formed? In fact, it is from carbonic acid. In the renal tubular system, carbonic acid is broken down to H plus and bicarbonate. So the H plus is removed through the protein channels by the action of aldosterone, but the bicarbonate is retained. Because of this, there will be increased levels of bicarbonate levels, leading to a metabolic alkalosis. So this is given the term contraction alkalosis, because now there is loss of fluid and also there is alkalosis as well. So thiazide primarily cause metabolic acidosis by uh, increasing the excretion of bicarbonate in the urine. So what it does is that this is actually a false statement. What it does is that is quite the opposite. It causes metabolic alkalosis. Right. So as loop diuretics, it does metabolic alkalosis by means of volume contraction. So this is a false statement. The contraction alkalosis associated with diuretic use occurs because the body reabsorbs more bicarbonate in response to reduce excessive fluid. Yes, that is the exact. Um, bicarbonate is actually an indirect process, but it causes retention of bicarbonate, and therefore this is the exact uh, definition that you can bring in to contraction alkalosis. So looking at the D statement, potassium sparing diuretics are more likely to cause metabolic alkalosis than other classes of diuretics. Now, looking back, potassium sparing diuretics are diuretics which acts on which such as spironolactone, amiloride. So these are some diuretics that has the potential to maintain or keep the potassium content. Because in loop diuretics as well as in thiazides, which causes, now if I go through a little bit of pharmacology. This is not relevant to you as well, but just a little briefing up. So there is loop diuretics that act on the Henle loop, which act on the sodium potassium chloride symporter, preventing this from happening, the reabsorption of sodium chloride as well as potassium, and therefore there is excessive production of urine, and hence there is diuresis. Along with that, there is a possibility of hyponatremia and hypochloremia as well as hypokalemia. And then there are thiazides which acts on sodium and chloride transporters, and therefore the sodium is lost as well, and hence it acts on, it again has a higher possibility to cause hyponatremia, but as a compensatory mechanism there will be aldosterone secretion, and hence there will be potassium loss as well, leading to the possibility of hypokalemia. So these are both thiazides and loop diuretics has a small possibility to cause hypokalemia. But when it comes to potassium sparing diuretics such as spironolactone, what it does is that it will prevent the loss of potassium, and therefore it maintains a good potassium content within the blood plasma. Now there is a separate channel there is integrated B cells which has this protein channel where potassium is reabsorbed and hydrogen ions are secreted, right? So what happens here is, because of this potassium sparing diuretics, there will be there is the activation of the potassium reabsorption, and therefore there is H plus secretion as well. But the question asks us about more likely to cause metabolic alkalosis than other causes of diuretics. Now the thing is, even though now this has good because of the potassium sparing diuretics, the potassium level is good. Potassium level is more or less normal. Therefore, this protein channel does not need to be much active. Hence, the H plus loss is somewhat reduced or diminished, because there's a good potassium content. The potassium reabsorption is somewhat reduced, and hence the H plus secretion is somewhat reduced as well. Therefore, the potentiality for a metabolic alkalosis to happen is rather reduced in potassium sparing diuretics in comparison to that of thiazides and loop diuretics. So what you would see here is that more likely to cause metabolic alkalosis, that's a false statement. That is, it is less likely, not more but less likely. Excessive use of diuretics can lead to hypokalemia. Yes, that's what I just said. Thiazides, loop diuretics, all can cause hypokalemia and even can exacerbate metabolic alkalosis. Right. The metabolic alkalosis is exacerbated by the fact the action of the RAS system, and therefore the bicarbonate retention. Right. So this is a true statement. So I have gone through some critical questions. These might be a bit difficult for you as well, but just think about the situation where you think about these clinical scenarios, because this is quite evident when it comes to appointments and your clinical routine, because you might see such patients coming with electrolytic as well as these pH imbalances because of the drugs that they take or because of the disease conditions that they have. So this is one tutorial that I have done in regard of physiology. So we'll be meeting with few more in the near future. Thank you.